Hi everyone, I am Dr. Wafaey Badawy, a senior consultant histopathologist. I'll be talking about pediatric type follicular lymphoma and in situ follicular B-cell neoplasm. Follicular lymphoma part 3. Pediatric type follicular lymphoma. Definition and general background. Pediatric type follicular lymphoma is a localized neoplasm of germinal center B cells. It accounts for 1 to 2% of childhood non-Hodgkin lymphomas. It occurs predominantly in the pediatric and adolescent age group. There is a marked male predominance with a male to female ratio of greater than 10 to 1. It is characterized by a clonal proliferation of germinal center B cells with a pure follicular growth pattern, a high proliferation index, absent B symptoms, absent extranodal location, excellent prognosis. Most patients present with a single enlarged lymph node in the head and neck region, or less commonly an enlarged inguinal, femoral, or axillary lymph node. Pediatric type follicular lymphoma shows low genomic complexity, lack of translocations found in other germinal center-derived lymphomas such as BCL2, BCL6, and MYC. Microscopic features. Lymph node demonstrates partial infiltration by a proliferation of atypical follicles with a rim of reactive lymphoid tissue, node-in-node phenomenon, no extracapsular extension, confluent atypical follicles, lacking zonation, starry sky macrophages, and a follicle mantle. Follicles consisting of intermediate sized cells between large centrocytes and smaller centroblasts. Follicular lymphoma grade 3. The lymph node demonstrates atypical follicles lacking zonation and mantle zone, some starry sky macrophages, uniform intermediate sized neoplastic cells with features between larger centrocytes and small centroblasts. Follicular lymphoma grade 3. The neoplastic cells have round oval nuclei, small nucleoli, finely clumped chromatin, and scant cytoplasm. That is blastoid features. Immunohistochemistry. The neoplastic cells co-express B cell markers such as CD20, CD79A, germinal center markers such as CD10 being frequently strong, BCL6, FOXP1, which is negative in reactive germinal centers. The germinal centers of pediatric type follicular lymphoma lack BCL2 protein, Neoplastic cells are also negative for IRF4 MUM1. The lymph node demonstrates partial infiltration of the lymph node by confluent atypical follicles expressing CD20, a rim of preserved reactive lymph node with well-demarcated reactive follicles. Atypical confluent follicles with increase of CD20 positive cells in the interfollicular areas. The Ki67 proliferation index is usually greater than 30%. The proliferating cells often lack polarity. The proliferation index is slightly lower compared with reactive germinal centers. Together with B cell markers such as CD20 and germinal center markers such as BCL6, dendritic cell markers CD21, CD23, and CD35 highlight the pure follicular architecture. Restriction of the neoplastic cells to the follicles. The relative absence of neoplastic cells in interfollicular areas. Therapy and prognosis. Virtually all cases of pediatric type follicular lymphoma manifest as limited stage peripheral lymphadenopathy without B symptoms. It has an overall excellent outcome and prognosis. Pediatric type follicular lymphoma does not relapse or progress even when treated by excision alone. There is no elevation of serum lactate dehydrogenase levels. Pediatric type follicular lymphoma does not necessarily require chemotherapy or radiation, with survival rates exceeding 95%. In situ follicular B cell neoplasm. Definition and general background. In situ follicular B cell neoplasm is defined as partial or complete colonization of some reactive germinal centers by follicular B cells with IgH, BCL2 fusion, and strong BCL2 expression in otherwise normal reactive lymph nodes or lymphoid tissues at extranodal sites. It can coexist in the same anatomical site with overt follicular lymphoma or other lymphomas such as chronic lymphocytic leukemia and marginal zone lymphoma. In situ follicular B cell neoplasm may also co-occur with in situ mantle cell neoplasm. This diagnosis cannot be made by cytology alone, as it requires immunohistochemistry of germinal centers. It is always an incidental finding, detected in approximately 2 to 3% of randomly selected reactive lymph node biopsies by immunohistochemical screening for BCL2. No treatment is indicated if only in situ follicular neoplasia is found. Microscopic features and immunohistochemistry. Lymph node with retained architecture along with secondary follicles and lacking features of classic follicular lymphoma. Two of the secondary follicles with germinal centers show partial colonization by cells strongly positive for BCL2. Neoplastic cells are confined to follicle centers of secondary follicles. Reactive germinal center is negative for BCL2. The neoplastic cells are strongly positive for BCL2, CD10. The abnormal B cells with strong expression of BCL2 and CD10 are limited to germinal centers and do not transgress the mantle zones or extend outside the follicles. CD10 expression is stronger in the in situ follicular B cell neoplasm cells, red circles, than that of the secondary follicles with germinal centers, blue circle. These are the references. Thank you.